I'd like to talk this morning about aspects of critical care in pregnant patients. Thank you for that introduction. As you know, the virus is called the SARS-CoV-2 virus, while the disease is called COVID-19. Now, because of the time constraints, I'm going to go quite quickly through this talk, but obviously if there are any questions, I'm happy to answer them. In terms of the virology, the incubation is around a mean of 5.2 days, which is important when one is looking at when we will do the testing. The range can be anything from 2 to 14 days. We now know that viral shedding continues for a median of 20 days, but can be up to almost 40 days. The signs and symptoms are listed here, the most common ones being fever, cough, fatigue, dyspnea, and rarely a sore throat or other features of influenza. The diagnosis that we rely on is nucleic acid amplification, and that is an RT-PCR test. You need up to 2 hours in general, even with the most sophisticated equipment. And we have found in our environment that it is certainly better to do this in a laboratory than at a point of care, simply because the systems are more sophisticated and can do more cycles and therefore amplify more. If you do the test too early, i.e., in the first hours after an exposure or even days after an exposure, you can get a very high false negative rate. So it is important. And at Texas Children's Hospital and Baylor College of Medicine, we tend to only test people after 5 days from the last exposure. You can see that there's a 20% false negative on day 8, a 50% on day 5, and if you test on the day of exposure, it's 100% false negative. The further down you go, the more sensitive. So clearly a bronchoalveolar lavage is more sensitive than a nasopharyngeal swab, which is more sensitive than sputum. In our situation, we're doing nasopharyngeal swabs in most people, and we're starting to test sputum. We do not rely on serology for initial testing. It's really only useful after 14 days of illness because this is an antibody test. Rapid antigen tests we found to be too unreliable. We do not use them. Now, imaging, certainly in the situation of a critically ill patient, and a lot of what I'm going to talk about today is going to be about the critically ill. So we do use chest x-ray and CT scanning and have found that CT scanning is the best diagnostic tool, but clearly it's not practical. We don't have a CT scanner in our intensive care unit. One of the things we do use extensively is lung ultrasound. Now, in terms of a chest x-ray, this is the first line, and it is in general normal in early or mild disease. Do not expect somebody who has minimal symptoms to have a terrible looking chest x-ray. It's much less sensitive than the CT scan. The most common times to see things would be 10 to 12 days after the onset of symptoms, and usually you'll see a patchy infiltrate, maybe some consolidation. It would be very rare to see the typical ARDS ground glass appearance. The distribution is usually bilateral, peripheral, and posterior in the lower zones. It's very rare to see a pleural effusion. In terms of chest CT, this is the most diagnostic. And I hope you can see my pointer, but this is quite a common kind of crazy paving view where you will see that the consolidation or that the opacities are posterior and peripheral in most cases. Here you can see that it can be patchy, but again, it is generally more peripheral. Now, ultrasound is something that is used a lot in an intensive care unit, and we use it quite a lot and very frequently in our intensive care unit at Texas Children's Hospital. So what do we see? Well, we see A lines and B lines. Now, A lines are, well, both of them are really artifact, but A lines you can see are horizontal and they decrease in terms of the density. And this is because it's a reverberation. This is an artifact that comes from air in the alveoli. So this is completely normal. Now, the B lines, these bright lines, again, are an artifact, but this comes from fluid in the alveoli. So it's only normal to see between 2 and 3 of these lines in any normal patient. So A lines and B lines, just 2 to 3 of them are normal. Now, what do we see in patients with COVID or any other viral type pneumonia? Well, you see an irregular pleura and no A lines. And this tells you that there's very little air in the alveoli. You also see that there are very confluent B lines. So there are many more than 2 or 3 B lines, and you can see them here, multiple B lines going down. And this is suggestive of the, or diagnostic of the consolidation. What about the disease progression? Well, in general, we'll see the onset usually over about a week. And we will then see that about 80% of the patients are mild to moderate, and about 13 are severe, and about 6% are critical. And over the next 2 weeks, we either see recovery or we see worsening. So this is in general, you know, pretty well from onset to recovery or death is over about a 3-week period. So there's certainly a lag in the disease. There are patients that will linger on ventilation strategies or ECMO, which we'll talk about in a little bit, and this can be as much as 3 to 6 weeks. Now, I'm not going to talk very much about mild disease, but in general, you know that there can be asymptomatic disease where the person is shedding virus or is positive but has 0 symptoms. We're not going to talk about that. And we're not going to talk about mild disease because we do not admit these patients. So even if you have a patient who has a cough and fever and myalgias, as long as they do not have dyspnea or tachypnea and abnormal chest imaging, we do not admit these patients. They are managed at home with frequent telemedicine. Moderate disease is defined as the mild disease, but now with any of the following: refractory fever despite giving Tylenol, dyspnea and tachypnea, abnormal chest imaging, abnormal arterial gas, and inability to maintain oxygen saturation. And we admit all of these patients. They require inpatient management, maybe on a ward, not in an intensive care unit, but we will monitor them very closely every 4 hours for evidence of getting worse. We recommend that there be this ongoing, and why? It's because we're looking for early warning signs, and this would be an increased sensation of dyspnea or the work of breathing. So if these patients start to struggle, this is a big warning sign. Inability to keep the oxygen saturation above 93%, persistent or more frequent fevers and worsening of the myalgias. And now when you get to severe disease, now you have a respiratory rate that is very high, greater than 30 per minute, hypoxia of less than 93% peripheral oxygen, arterial saturation, and now a need for increasing amounts of supplemental oxygen, a PaFiO2 ratio of less than 300, and more than 50% lung involvement on imaging. These are the defining criteria for severe disease. Here you can see the disease initially being peripheral on chest X-ray, but then progressing to much more widespread. And this is typical of any viral pneumonia, but certainly something that we would see with a patient with worsening COVID-19. What are the diagnoses to make, or what are the criteria to make a COVID-19 ARDS diagnosis? They're the same Berlin criteria that we would use for anybody with acute respiratory distress syndrome. Mild would be a PaFiO2 ratio of 200 to 300, moderate 100 to 200, and severe less than 100. So as you can see, the mortality increases as you get worse severity of the ARDS. Now, remember that this is not simply a disease of the lungs. This is a multi-system disorder, and we are certainly seeing this, and you've heard about it in children, but we're seeing and learning more and more about the long-term effects of COVID-19. And I'm sure that over time, we're going to understand that this is simply not a lung disease, this is a systemic disease. So you will see CNS complications in about 50% of the critically ill COVID-19 patients. Headache, dizziness, myalgia, this list of CNS symptoms. It's unclear at the moment whether these are primary to COVID-19 or whether they're just complications of a critical illness. About 1 to 3% of these patients will stroke, and very rarely you can see much, much more severe central nervous system complications. Acute disseminated encephalomyelitis, meningoencephalitis, myoclonus, and even posterior reversible encephalomyelopathy. Not only does it affect the brain, but it affects the heart. And I think you've all heard about COVID heart. This is in general diagnosed by an elevated troponin, and we see evidence in these critically ill patients of stress cardiomyopathy, hypoxic injury, ischemic injury caused by cardiac microvascular disease or epicardial coronary artery disease, and the very well-known cytokine storm. A minority of these patients will present with symptoms and signs of an acute coronary syndrome. When we look specifically at pregnancy, we have current data from the CDC on around 8,000 pregnant women. That's about 9% of the total number of patients for which the CDC has data. And what we see is that in pregnancy, we're more likely to see women with comorbidities. These include chronic lung disease, diabetes, and cardiovascular complications. Statistically higher levels of hospitalization occur in pregnancy, of ICU admission, and mechanical ventilation once admitted. However, what is interesting is we're not seeing any difference at the moment that is statistically significant between people who die from COVID-19 based on pregnancy. So pregnant women do not appear to die at a greater rate from this condition. How do we treat in our intensive care unit? A lot of what I'm going to talk about now is what we're doing at Texas Children's Hospital. We have had more than, in our system, more than 100 patients, pregnant patients in ICU with COVID-19. So we now have quite a lot of experience in the management of these patients. Regular nasal cannula, maximum up to about 15 liters per minute, but most patients, once you start getting above 8 liters per minute, struggle to tolerate nasal cannula. As you know, in the first part of this disease treatment, when we were learning from New York, a lot of patients were getting intubated. We've now learned that that is probably the last thing you want to do. And so now strategies have moved much more to less invasive methods. And so a lot of supplemental oxygen strategies have now been developed. So initially, high flow nasal cannula. If the patient cannot tolerate a regular nasal cannula at above 8 liters, we move to a face mask. If they're unable to tolerate a face mask at about 15 liters per minute, we'll go and try high flow nasal cannula And this is quite remarkable. You can get almost all patients can tolerate up to about 40 liters per minute on high flow nasal cannula. And some people have even been as high as 60 liters per minute of high flow nasal cannula in an attempt to avoid intubation and ventilation. If you have a closed circuit system or a negative pressure room, then non-invasive positive pressure strategies with BiPAP or CPAP are possible. But clearly, because this generates an aerosol, you have to have full PPE, and you have to be in a situation where you are not venting the aerosol into the general circulation of the hospital. So, regular nasal cannula, face mask, high flow nasal cannula, and if you have the ability to give BiPAP or CPAP, we'll move to that before intubation. I want to talk for a second about prone positioning and why it is important. You can see here that when a patient is lying supine, the fluid that would be collecting is going to start collecting in the posterior area of the chest. When you look at the chest, there is much more lung in the posterior area than there is in the frontal areas because of the position of the heart. So if you're filling up this area of potential lung space with fluid, it's less available. By flipping the patient over, now you're filling up an area that has less lung tissue and opening up more lung tissue posteriorly. This is the theory of why we prone patients. We're able to get a much better ventilation perfusion ratio. You can do this in two situations, either passive, where the patient is not intubated, the patient can move or position themselves, and you can either do this laterally, changing position every 2 hours, or even full prone. And we have published on this in the Green Journal very recently to show that this is of benefit and how it can be done, either in a lateral decubitus position or in a full prone. Clearly, in intubated patients, this can also be done, but obviously the patient cannot help you in that positioning, and it has to be done for longer periods of time. Now, when do we call it critical? We call it critical when there's obvious respiratory failure now requiring mechanical ventilation. So once you intubate and ventilate a patient, this is a critically ill COVID-19 patient. When that patient develops multi-organ dysfunction or failure of multiple organ systems, when they develop shock, and that would be a mean arterial pressure of less than 65, refractory hypotension, and evidence of end organ hypoperfusion. This is a critically ill patient. When should we intubate a patient? Typically, I've given you these numbers already, but when they fail with supplemental oxygen, when they're unable to protect their airway because of altered mental status, and you've heard of COVID brain, these patients sometimes are just simply unable to prevent aspiration, and so, as in any pregnant patient, intubation is protective. And then when they're becoming too tired and they're becoming exhausted and cannot breathe effectively anymore. If you are going to intubate a patient, make sure it's done by the most experienced provider. This is not a situation where you want to train somebody to do intubation. It is also best done with high technology, and if you have video-assisted laryngoscopy, whereby you can actually stand back from the patient to some extent, not expose yourself to the potential aerosol, and you can see what you're doing on a video screen. This is, certainly in our experience, very useful. Remember that during the intubation process, the baby may well show temporary non-reassuring status, and this is not an indication to immediately rush to cesarean section or do a cesarean section in the intensive care, because most times those babies will recover. Now, if after intubation and reinstitution of the best possible oxygenation, the baby is still showing signs of compromise and is viable, obviously you will move to cesarean section. It goes without saying that when dealing with these patients, full PPE must be worn by the team. We have performed one placenta percreta surgery in full PPE. This was a 4-hour surgery. And here you can see I'm wearing a cooling vest, which became very, very important, and a full purified air, pressurized purified air system with PPE. It's very uncomfortable, but in this case, everything went well. We've also done a laser for twin-twin transfusion under the same circumstances. Now, what are our treatment options for pregnant women with critical COVID? It's largely supportive. You want to optimize ventilation, as I've spoken about. There are ongoing clinical trials, but these drugs should really be only used in a clinical trial. And I'm going to talk about what we use at Texas Children's Hospital in a moment. Remember that the Society for Maternal Fetal Medicine advocates inclusion of pregnant women in as many clinical trials as possible, and this is part of an inequity in research at the moment, where pregnant women are actually excluded from too many trials. So one of the drugs that we use on all of our critically ill and severely ill patients is remdesivir. If we admit a patient who is having breathing issues or requiring oxygen, we'll treat them with remdesivir. Now, remdesivir is a drug that has been treated or has been used, and the primary study was that published in the New England Journal was on over 1,000 patients randomized to remdesivir versus placebo. It was given as a 10-day course, 200 milligrams IV for 1 day, and then followed by 100 milligrams IV for the remaining 9 days. The primary outcome was shorter recovery in the remdesivir group, a median of 11 versus 15 days, and there's no significant difference in adverse effects, so a reasonably safe drug. Is it best to give it for 5 or 10 days? And here's another study that followed up, and the current advice is if you have a patient requiring mechanical ventilation, then we give remdesivir for 10 days. If the patient is on oxygen with supplemental oxygen, either nasal cannula or face mask, then we give 5 days if it's not a mechanical ventilation method. What about dexamethasone? I think this, as a result of the recovery trial, has been an important addition. And the recovery trial published in the New England Journal also showed a large number of patients, 2,100 patients randomized to IV or oral dexamethasone. Now, these were not all pregnant patients. In fact, a very small number of patients were pregnant. So the data are possibly a little shaky for pregnancy, but we're certainly using dexamethasone in our pregnant, critical, and sick patients. The primary outcome was a decrease in 28-day mortality in patients on mechanical ventilation or supplemental oxygen. So I think that it is important. This is not for simply a symptomatic patient, somebody who comes in and is sick or coughing, but does not require supplemental oxygen or ventilation. This is only for this specific group of patients. In fact, there was a trend to harm. It's not statistically significant, but a trend to harm of patients who did not receive respiratory support and who were given dexamethasone. This paper has just been published, and this is by Antonio Sard from UTMB, just down the road from us, and looking at pregnant patients. And this is their current recommendation. So you can look at this algorithm. You've got a pregnant woman who is on oxygen therapy or ventilation. Are you going to give this patient glucocorticoids for fetal lung maturity? That is between 24 weeks and 33 and 6-7 weeks. If you are not going to give them, if the patient is outside of that window, either pre-viable or beyond 34 weeks, then they would give that patient methylprednisolone in the dosage shown here. If the patient is, they are recommending dexamethasone, which is the alternative to betamethasone, for 4 doses, that's for 2 days, then switch to methylprednisolone. We have changed that at Texas Children's. Instead of using dexamethasone, we give our regular betamethasone, 12 milligrams, Q24 hours for 2 doses, and then we switch to the methylprednisolone for 8 days. Other considerations: antibiotics, anticoagulation, convalescent plasma, hyperimmune globulin and monoclonal antibodies. And I just want to talk very quickly about antibiotics. If you have a suspicion for community-acquired pneumonia, you should be giving antibiotics, and you should give them within 45 minutes of admission. So as soon as you say this patient may have a community-acquired pneumonia on top of the COVID, then we give ceftriaxone and azithromycin together. If the patient develops a hospital-acquired pneumonia, we give much broader spectrum antibiotics, and we use our infectious disease experts to tell us which drugs. What about anticoagulation? If you are going to anticoagulate, use unfractionated heparin, not low molecular weight heparin, because we need to have, in our critically ill patients, we need to have the ability to quickly reverse the anticoagulation. In general, we will use prophylactic in those people who are not severe or critical, and we will give full unfractionated heparin to patients who have severe or critical COVID-19 disease. Remember, if you're treating somebody with unfractionated heparin in these kinds of dosages, or any patient getting unfractionated heparin, initially it is always good to look out for heparin-induced thrombocytopenia, which can be diagnosed using the 4T's score, and you can see here how to get that. ECMO, we have had 1 patient who required ECMO and an aortic balloon pump. She was very, very sick, and she survived. Unfortunately, her baby died, but she survived after a long period. I think that you have to be aware that nobody thus far that I know of has used arterial venous ECMO. The only ECMO that's been reported in pregnancy has been venous ECMO. The initial reports are encouraging. So if you have it available and you have an experienced team in giving ECMO, we fully recommend that you use it in these desperate situations. Thrombosis and bleeding are definite complications, and I think that we have to be very careful, and this is why you need an experienced team. What about convalescent plasma? Now, we have been using convalescent plasma to give our patients passive immunity, and there have been 2 big trials. The one that we're participating in is the Mayo trial, 35,000 patients and more. And there's been a smaller trial at Methodist Hospital in Houston of 136 patients. We would only recommend use of convalescent plasma to give passive immunity in patients who are on a clinical trial. And in fact, about 3 or 4 days ago, the FDA put out a hold on emergent or emergency authorization, i.e. where the general public can use it without a clinical trial. And they are concerned and looking at the data. So we're continuing to enroll patients in the trial, but the FDA is a little concerned about whether this actually works. This is not a treatment. It is not to be given to people who have life-threatening disease. And if you are going to use convalescent plasma, it should be given early in the disease and only in severe disease, but not to the critically ill. So this is not a treatment, as I said. Hyperimmune globulin, still very experimental. We're not using it at our institution, and same goes for monoclonal antibodies. These are being used experimentally. There certainly is no current evidence to recommend the use of hydroxychloroquine, ACE inhibitors, or angiotensin receptor blockers. IL-6 inhibitors, as we've just spoken about, this influenza treatment, favipiravir, interferons, and lopinavir, ritonavir for HIV. None of these drugs clinically should be used unless it's in a very specific clinical trial. And that's the end of my talk. Thank you very much.